So today we're going to be doing an image presentation for femur. This is the St. Mary's group, femur trauma or trauma.
Okay, our patient is a 66-year-old female. Her history is that she missed a step near the bottom of the stairs and she fell. She also has a history of osteoporosis. The reason for the exam is that she fell, and she has pain in the left femur. The procedure requested was femur, 2 views of the proximal and distal femur.
Okay, so the impression was a transverse fracture of the midshaft of the left femur. The distal fragment is displaced medially and approximately 0.5 centimeters proximally in relation to the proximal fragment. The fracture line extends through the proximal end of an intramedullary rod. So you can't really see it too much here. You can kind of see here where the bone is overlapping because it's not aligned. But you can visualize it better in our other images we'll be showing later on.
Okay, so I'll be presenting the AB proximal femur. Are there any unnecessary articles? Yes, you can see the immobilizer, but it's supposed to be there. We're assuming that the patient came with that and it was probably put in by paramedics in the ambulance. She came in the ER. The central ray entered, it's perpendicular and entered to mid-femur, and it was centered in the center of the IR. There was no angle. The anatomical part is not oblique. Which body plane? It's AP. The top of the IR is placed at the level of ASIS. Everything is properly demonstrated, and what you can see best in this position is the hip joint, the femoral neck, femoral head, femoral body, and the greater tuberosity. Is there any rotation? I believe there's not. Both tuberosities are on profile. I just think that the lesser tuberosity is a little too much in profile, but that's because the patient couldn't rotate their leg internally 10 to 15 degrees as they should be. Is the radiograph showing proper density? Yes, different shades of gray, as well as some tuberculation. There's no motion in the image because there's no blurriness. It is marked properly. You can barely see the marker, but it wasn't implanted. Collimation, I believe that it could have been collimated better because for this projection you don't really need the pubic symphysis joint. The techniques used for this image was 75 at 18.85. AEC was utilized and the cell was the middle cell. A resultant S number is 0.98. It was in the green. Were there any repeats necessary? I believe that there are no repeats necessary. Any pathology? Transverse fracture, which is a type of broken bone where the break is at the right angle to the bony plane of the bone. To the long plane of the bone. And critical thinking was used. The tech used a sliding board to get the patient to the bed to prevent more injury. And I would give this image an A-. I believe it's a good image. It just could have been collimated a little better, but in this situation, that's the tech had to move quickly, and they still got the whole proximal femur and the hip joint and everything that was necessary. So I give it an A-.
Go ahead.
Okay, so now I'm going to be presenting the AP distal femur, the left femur. So for this projection, the patient was supine. So are there any unnecessary articles? So yes, like Alex mentioned before, the mobilizer is in the soft tissue, but it's helping support the patient's legs. So in this situation, the object in the way right here is okay, because it's for the patient's benefit. And it's not even obscuring any part of like the bone here, so that's okay. The central ray is supposed to be centered mid-femur, so in this case, it's a little bit off, I would say, because we already had the upper portion. They did two separate images. So in this case, we went a little bit lower, and you do want to see the knee joint as well. So the tech should have had at least 2 inches of light below the knees, and I would say the knee joint, and I would say here they had maybe like 1.5 inches or about there. And MSP to the part. There was no angle on the tube for this image. The central ray was perpendicular, and the part was not obliqued. If it looks any sort of rotated at all, it would be due to the fracture, and we can't necessarily adjust that, of course, due to the patient's condition. The part I would say is properly demonstrated. You can see the distal femur and knee joint, and here the fracture is better visualized than the proximal portion of it. We did find out for this patient, they also ordered knee views, so a few knee x-rays. So, of course, the tech didn't necessarily get all of the, how do you call it, the hardware here. The tech didn't necessarily include it all, but that was fine because they did know they were doing the knee anyways. So that's why it's not best visualized here. However, in those other images that we don't have, it was visualized. The rest of the hardware was best visualized. So anatomical structures that are demonstrated in this position or projection are the distal femur, the knee joint, so the medial and lateral malleoli, so medial and lateral, or epicondyles, I'm sorry, not malleoli, epicondyles. The patient's knee rod here, most of it, you could see the proximal portion of it, not really the distal, but you could see where the base of the proximal tibia would be, like the tibial plateau, that's where it would be. You could see the transverse fracture better, of course, and of course soft tissue. So for rotation, I said that yes, like I mentioned earlier, most likely because of the patient's fracture. But since we can't adjust it, of course, there's nothing you can do about that. Maybe a tube angle could help compensate, but I would say it's better to see the anatomy as it's visualized, not mess with it so the doctors really know what's going on. I would think that would be better for them. Is the radiograph showing proper density and contrast? I said yes, because you can see the different shades of gray, many shades of gray. Also, the image was in the range and in the green. There is no motion in the image, and also I don't think there would be because the immobilizer is supposed to keep the patient from moving their leg, so there shouldn't be motion because the patient shouldn't be moving their leg. The film was properly marked, so where'd it go? It looks like I got clipped off here, but when we viewed these images in PACS, you were able to see the marker better, but it's right here, and it was showing the complete marker. They did not implant the marker. It was a left marker that they did place on there, the tech placed on there. The image is collimated, but I feel it could have been collimated a little bit better. They could have gone in more. We didn't necessarily need, you could see soft tissue of the right leg here. We didn't need that, so we could have gone in a little bit more. So the technique used for this one was AEC. AEC was utilized for and the technique was 75 at 2.32, and the center cell was utilized. The S number was 1.44 in the green. And the range typically for this would be 0.56 to 1.68. For this image and this view, there was no repeats necessary. And the pathology, of course, was the transverse fracture and the transverse fracture of the mid shaft, and then the displacement of the femur due to the fracture. Um, Critical thinking skills that were utilized were, as Alex mentioned earlier, just the how to transfer the patient onto the bed with a sliding board to cause less to not cause any more harm. And of course, you want to work as a team, not just by yourself, because you could hurt yourself or the patient. You want to work with somebody else, help you move the patient over and place them onto the sliding board. So for this view, the tech didn't really necessarily need to touch or move the patient at all, which they also avoided doing as much as they could. And for this, I would say I would give the image an A because all anatomy needed is demonstrated. The tech used critical thinking to obtain the best possible diagnostic images under the circumstances. The patient was shielded. Even though the tech was moving fast, she still wanted to make sure she protected the patient. And the tech explained the exam to the patient as they were doing the exam, especially since the patient's already, in pain and they're not as comfortable in any position. So the tech made sure to have the patient be comfortable, especially by explaining what was happening.
Alright, so this is a proximal lateral projection of the femur. There is still some unnecessary articles in this image. Of course, the patient had the immobilizer on, so we can see the clip holding the strap on there and a little bit of the rod for support right there. Centering, since they were shooting for not both joints in one image, centering was a little higher up than mid shaft. The anatomical part was oblique. They rotated the leg outwards as much as they can. Obviously the patient couldn't bear it too much, and the rest was made up with tube angle. The anatomical body plane that the CR was entering was the medial lateral portion of the femur. I would say the anatomical part is properly demonstrated.
Yeah.
We were shooting for the proximal end. We got that. Over here we have the head, we have the neck, we have the surgical neck. You can see the lesser greater trochanters partially superimposed, shaft all the way down to the fracture. And of course soft tissue is also included. There is rotation of the part, but again that was intentional because we're trying to go for a lateral, so we wanted to get the part as true to 90 degrees as possible. I would say the radiograph is showing proper density. There's lots of shades of gray. You could differentiate between soft tissue and bone. It appears that there's no motion. Everything's really clear. The marker is right there, so it is properly marked. The left marker on the outer portion of the left femur. Technique used was 75 at 5.21. That resulted in an S number of 0.67, which was in the green. Photo AAC cells were used. In this case, it was a center cell, and the range for it should have been 0.56 to 1.68. We do not believe any repeats were performed, and they weren't really necessary because this was a limited study. The patient couldn't move too much. Pathology for the image. Again, transverse fracture at the midshaft of the left femur. Critical thinking for this. Again, we had to oblique the patient, probably use a couple sponge to help the patient be more comfortable, and use the tube angle to make up for the rest of the movement that the patient couldn't. For this image, I will give the tech an A because we got all the way up to the femoral head, all the way down to midshaft where the fracture is. Most soft tissue. It's collimated decent. It could have been moved over a little bit more, but overall, I give them an A.
Okay, and the last image we had of this patient was a lateral of the femur, supposed to be the distal end of the femur here, but they clipped the entire knee joint here. You can't even see the condyles on the knee, on the femur. but as Lupe said earlier, they did a total knee X-ray, probably 2 views, and that included the joint and a lateral of the knee. So the tech just sort of skipped over the knee and took what they got from this image. There are a few things in the image, but nothing is obscuring this very clear fracture here. There's the bands here. It's kind of hard to see, but there's like striations here across the image and along here. The marker's almost in the soft tissue. The clip is way out of the way, but also, you know, in there, as well as the immobilizer that's connected to the straps. For this image, the tech centered mid-shaft and right about here, right on top of the fracture almost, but didn't quite drop it down all the way to include the joint there. The central ray wasn't, normally wouldn't be angled at all for this image, but I would guess that they angled a little bit to sort of try and obtain a more lateral view of the femur, since the patient's movement was very limited. The anatomical part shouldn't really be oblique, but it looks to me like it's just a little bit not quite MCP. But with a fracture like this right across the hardware, it's going to be tough to get a perfect 90-degree angle for the patient's lateral. I would say that the mid shaft down to the knee joint, since it's not included, is well demonstrated. It's clear of all this stuff on the sides. There's no unintentional rotation or rotation that the tech could have fixed to make the image better. I think that every bit of rotation in here is as much as the tech could obtain with a patient that's split their femur into 2 pieces. The marker was implanted. It was probably sitting right outside the image. As for collimation, I think this isn't too bad. Of course, they missed the bottom part, but it is only the leg here that's included on the x-ray. No extra legs over here are included. For the exposure, I think it might have been a little bit under. There are lots of shades of gray, but it's difficult to see any trabecular detail within the bones. Let's see. The technique used was 75 kVp at 5.6 mass, resulting in an S number of 0.33, which was yellow, just outside of the range of 0.56 to 1.68. There weren't really any repeats necessary in this point, or at this point. They were going to do a knee x-ray or had already obtained the lateral of the knee x-ray, so I suppose that they decided to not repeat any images for the patient's sake, just to get them back to the room. And I believe right after this they ended up going to surgery on the same day. For critical thinking, we mentioned previously that a sponge would be needed to help the patient hold the position, especially on a lateral lay on top of this fracture. Also, the possible tube angle to sort of obtain a more lateral view. Any sort of tube angle probably would have helped, although elongating and distorting the bones a little bit. I think it would have been something you could do in the critical thinking case. As for a grade given for this, if there wasn't a lateral of the knee, I would give this a pretty poor grade because the joint isn't on there. But because of the whole knee x-ray coming in after this and included a pretty nice lateral, considering the circumstances, I would be okay with sending this through. I would say for this image maybe a C if it wasn't including the knee x-ray, and an A if it does. Is that okay? And that was that. Okay, that was St. Mary's.